Hello, everyone, and welcome to another edition of the Paper of the Week, McMaster Perspectives. I'm pleased to be joined today by Dr. Leslie Martin, who's an associate professor in the Department of Medicine, McMaster University, program director of the Core Internal Medicine program, but relevant to today's discussion, also a member of the Addiction Medicine Services and also part of the Smart program, which aims to help people who are homeless or are vulnerable with their health care needs. Welcome, Leslie.
Thank you for having me.
The topic today obviously is one that's of great importance, not only to medical professionals, but to society in large. And we can trace the opioid epidemic, if you will, back to the mid-1990s, of course, has been accelerated in recent years. So this paper that we're discussing is, I think, very timely and very important. To set the stage, can you give us a little bit of a background from your perspective about managing people with opioid use disorder, just some general principles?
Absolutely. Yeah, and this is obviously a topic near and dear to my heart. When we created we've changed the title of our service now to substance use service, but when we created it, it was very much in response to the opioid epidemic and shifts and changes that we'd seen in our patient populations presenting in Hamilton, but also across Ontario and nationally. The numbers reported in this study are actually slightly higher than the opioid-related deaths that we see locally in our area. We see about 25 per 100,000 patient population. In this study, it went up to over 50 in certain of their catchment areas. In terms of the treatment for opioid use disorder, much of it was captured in the study. So you want to look at harm reduction related practices, naloxone kits being one of those, and teaching people about safe use practices, test dosing, not using on your own. And then obviously many other things that we've seen roll out in our communities, like safe consumption sites and less toxic drug supplies and things like that, which really align with our harm reduction policies and approaches to care. In addition to that, they mentioned opioid substitution therapy or opioid agonist therapy. It wasn't clear to me in this study, given the range of interventions that were offered, exactly how many were implemented and which specific aspects of opioid agonist therapy were offered. If you look at our Canadian guidelines, buprenorphine is considered first line as the medication of choice for treatment of opioid use disorder, and that's buprenorphine naloxone in Canada is how it's formulated. So I don't know what percentage was offering the first line treatment that we would consider. And then other opioid agonist therapies that are considered second and third line would include methadone and sustained release oral morphine. And there's very strong evidence to show that there's mortality benefit to offering such treatments to individuals and higher risk of opioid-related overdoses and deaths at times of initiation until you're stabilized, as well as at times of change in your doses. So if you start to taper down, for example. So yeah, the other thing as well is kind of wraparound care. And again, we don't know that much about the communities here, but housing, access to counseling services, those types of things as well. That would be part of our patient-centered approach to care that's quite multi-pronged.
Okay, so let's move on to the study. It seemed like it was a very ambitious study done in the United States during the throes of the pandemic. And what are your kind of takeaways in terms of the methods used? Like they aim to implement quite a number of recommendation, and at the end of the day, there did not appear to be a mortality benefit. So maybe you can just kind of walk us through the study, what you thought of the intervention, the methods, and how you might interpret the result.
Yeah, I guess the first thing I'd say is I was very excited to see this published in the New England Journal of Medicine. It aligns with local research that we have tried to do in terms of providing patient-centered care, multi-pronged aspects of care to individuals. And as you said, quite ambitious across the number of people in the number of different communities, and trying to create a randomized control design here to compare communities where they rolled out these interventions to communities where they had yet to do so, and then rolling those communities in kind of after the fact. So to summarize the study, they included 67 communities, which included 8.2 million people. So again, a huge number of individuals that they were trying to capture in their study. And then they either assigned those to the intervention or to a comparator arm. And they tried to include both rural and urban communities in their approach. And then my understanding is that they offered a huge range of interventions, and they tried to engage peer workers and people with lived experience and people within the communities that have worked with these patient populations to determine interventions that would work well within their community. And they gave some roll-in time, and then they had a study window. One of the limitations, I think, because of the pandemic, and we saw this locally, is that they were trying to roll out these interventions at a time where there was huge resource constraint. And they do speak as one of their limitations about how that could have impacted both the implementation of those interventions, as well as perhaps the recruitment and retention of individuals that were involved in that. And I have to fathom that played a part in whether they were going to see an impact of this, because we saw that locally in much of our work. It was hard to enroll people, hard to maintain study staff, hard to get study staff into spaces during quarantine and things like that. And so of the strategies that were selected, I think they highlighted 615, only 235 were actually implemented. And in terms of, evidence-based care, we know that opioid agonist therapy has a huge impact, and only 36% actually involve the use of medications. So perhaps some barriers to implementing some of the evidence-based care that we might have suspected to impact the outcome of interest, which was opioid-related death or mortality in this study. That's the main outcome that they focused on. They did also look at adverse events, and I believe that they defined those as accessing of emergency-related services. So where, it wasn't a death from the opioid overdose, but perhaps accessing emergency services in the setting of an overdose event. In terms of the window of observation, it was only 1 year that they had articulated as their window of observation. So if you do look at the breadth of the interventions that they were trying to implement, the time frame with which they were implementing those being in our pandemic time period. Again, they highlighted this as a limitation. It was one of the first things that came to my mind is, was there sufficient rollout time to impact the outcome of interest, which was mortality? And then as well, the spread of the different interventions that were implemented. And they actually had a hard time capturing the number of individuals that were exposed. So they described some of the education as being, social media, posters. That makes it very difficult to know the individuals that maybe crossed paths with that content that would have benefited from it. And so they really weren't able to, they were able to say that as a single service had been delivered, but they weren't able to say the number of people that had witnessed that resource to hopefully benefit from that resource. So I think for me, when we talk about the limitations, if you're okay for me to go there, I think this is a really great thing that they tried to do. And I think it aligns with much of the work that we've tried to do locally. And my hope is that with more time to actually implement, with more resource, perhaps recognizing the constraints in the pandemic, as well as time to capture the impact of their intervention, that we might have seen greater impact from this. That said, it is a very complex space, and I do think mortality is only one outcome of interest. Obviously, in a big study like this, it's very difficult to look at more nuanced outcomes. But work that we've done locally has really tried to look at patient experiences, cravings that they're experiencing while they're on their opioid agonist therapy. If we are making patient-centered differences, that maybe won't be captured by mortality alone. So I think because of the breadth of their study, mortality was a really logical outcome and quite easy to measure in comparison to those more nuanced metrics, which would be difficult in such a big study, but it's not the only outcome of interest. And perhaps there's other things that this intervention benefited the patients that wouldn't be captured by mortality alone. So I think kudos to the team. I think it's a really great piece of work that they did, and should not be undermined by the fact that it didn't shift their outcome of interest.
So just to finish off, then it seems like this, in a way, reinforces what you're doing in your day-to-day practice and maybe provides a springboard for future research, or maybe there will be additional analyses coming forth from this work. But would you agree with that, or is there something that we need to look at in terms of next steps here?
Yeah, I think absolutely it's a springboard for future research. And I would just hate to see people say, okay, now we stop here. This study was done. It was an RCT, which is great and actually fairly rare in this space. And we didn't see the needle move, so we should stop trying. I hope nobody takes that message away. I think what it lets us know is that it's a complex space to work in. Multimodal approaches are definitely the right way, but measuring the impact of those multimodal approaches is nuanced and can be challenging. And so let's not give up here. Let's keep chipping away at this.
Dr. Leslie Martin, thank you so much for providing your insights and continued success in your area of work. It's very important. Hopefully we'll see some more research in this area, and this is just a major first step forward. So thank you again very much for joining us.
Thank you for having me.